I'm going to get started so that we have lots of time for questions at the end, because we're going to have lots of questions about this topic. So welcome. I think more students are going to walk in. So Charles Donahue, for whom this lectureship is named, has been a great friend to the Boston University School of Public Health. But before finding his way to SPH, he had a long history in the world of health. After spending his undergraduate years at Brown University, where he was a star hockey player, Mr. Donahue began his career in international health, working as a Peace Corps volunteer with the Tuberculosis Control Program in Malaysia. Upon his return to the U.S., he ascended through the Massachusetts Health Research Institute, where he organized a framework for planning perinatal health services, then on to the BU Center for Health Planning, where he was the Director of Health Plan Development, and then to the Health Planning Unit of the Public Health Service of the HHS, where he oversaw the health planning agencies in 3 states. While working at those agencies, Mr. Donahue became interested in ways that science-based policy changes, grounded in solid epidemiologic techniques, could improve maternal and child health. Along the way, he co-authored academic studies, published notably in the Journal of the American Medical Association, the American Journal of Obstetrics and Gynecology, Archives of Pediatrics, and New England Journal of Medicine. When he entered the private sector, he co-founded and served as president of the Healthcare Value Management, based here in Massachusetts, where he helped build New England's largest network of healthcare providers used by self-funded preferred provider organizations. Remember those? He also raised a family with his wife, Nancy. Raise your hand. And had a daughter who went to BU, Carolyn. Raise your hand. I'm sorry to embarrass you, but I have to do that. Who's here this afternoon? So, Carolyn, like her father, by the way, was a varsity hockey standout and is a BU SPH alum and is now a lawyer in the healthcare field. So Charlie joined the Dean's Advisory Board a few years ago, where I had the great opportunity to meet him. He's always had a deep interest in the city of Boston and tackling the myriad challenges inherent in healthcare planning for a diverse urban area. And that interest, combined with his lifelong experience in and curiosity about the healthcare system planning and management, led him to endow this lectureship. Thank you, Charlie. I'm just going to applaud because the second year of this lectureship, and we're just delighted to have it here. So this year, we're fortunate to have as our speaker Dr. Asaf Bitton, whose talk today is entitled, as you see, Where Primary Care is Going in the U.S. Dr. Bitton has already, at his young age, had an illustrious career. He is a primary care physician whose eye is trained on populations and systems. Like Mr. Donahue, Dr. Bitton spent his undergraduate years at Brown University, where he went on to receive a medical degree at UCSF and continued his training in internal medicine at Harvard and received an MPH from the Chan School. Dr. Bitton has transformed primary care practice at various levels. He worked within his own group at Brigham and Women's to create a team-based primary care practice serving patients with complex psychosocial and clinical needs. He stepped up a level to lead the Academic Innovation Collaborative, a 2-year effort to transform 20 academic primary care teaching practices across Harvard's hospitals into patient-centered medical homes. He stepped up again to become a senior advisor to the Center for Medicare and Medicaid Innovation, where he helped mold Medicare's largest primary care initiative, known as Comprehensive Primary Care Plus, encompassing 13,000 clinicians in nearly 3,000 practices serving 15 million patients across 18 regions. Then he expanded, if you can believe that, moving internationally as one of the leaders of the Primary Healthcare Performance Initiative, launched in 2015 at the United Nations by the Bill and Melinda Gates Foundation, the World Bank, and the World Health Organization, which was to strengthen primary care health systems worldwide. His research has moved to quantifying the value of primary care and better ways of paying for it. And this year, he was named director of Ariadne Labs, which will look into solutions for large systems of care that are fragmented or dysfunctional here and abroad. On a personal note, I've known Asaf as a warm and caring clinician who is equally adept at big ideas and intimate moments. These qualities embody what Mr. Donahue was after his entire career, so please join me in welcoming Dr. Bitton as our second Donahue lecturer.
Well, it's so nice to be here today, and I just want to thank the Donahue family for this wonderful lectureship, and I hope that you'll find these comments provocative and useful, and for the students and faculty in the room, hope to ignite a conversation around what, as Michael was saying, is clearly my passion, which is primary care and primary care systems. It's important to disclose things. My first area of research was in tobacco control, and I actually studied non-disclosure and tobacco industry malfeasance, so I will declare my conflicts of interest here. I serve as a senior advisor, as Michael said. I am not here to speak on behalf of Medicare. If you have a problem with Medicare or Medicaid, I'm happy to take the comments in, but I'm not speaking on behalf of them. They remind me on almost a daily basis. My wife does work for Optum and the advisory board company, but that relationship doesn't have any bearing here. So over the next, I'm going to try to do this in 40 minutes. If I speak a little fast, that's okay. That's more time for you to speak at the end. I'm going to take us down a framework for how many of us think about primary care nationally and globally. We're going to talk just for a little bit. I don't love problematizing, but we do need to talk in primary care of the challenges that we face in the US. Then we'll talk about 3 possible areas or trajectories that primary care could and will go into. We'll debate their relative merits and likelihood, and then we'll end with your comments and discussion. So I'm going to start with the frame. I'm what I would call a Starfieldian. I have been deeply influenced, as I know some of you have, by the work of Barbara Starfield, one of the great theorists and practitioners of primary care, who made what now sometimes seems like an obvious point, but is a fundamental point to where I come from, which is that primary care is not actually a service line or a service per se or a staffing ratio or a set of collected degrees, but it's actually a set of interrelated functions, functions that we can name, functions that we can measure, and functions which, if performed well for a given population, there is massive, overwhelming evidence that they are associated with better health at more reasonable costs. And those functions are the following. I call them the 5 C's. You can call them whatever you'd like, but they revolve somewhere around this: the capacity of a system or a team or a group of clinicians to provide the first point of contact for 80% or more of a population's health needs, longitudinal continuity, which is the relationship. I call it the Cheers principle, where someone always knows your name, right? This is the opportunity to engage and build in a long-term healing relationship with people who know you and have the information about you over time. Comprehensiveness, which is a focus on a person integrated within themselves, so they're not just a set of organs or diseased organs in a pathological way, but they're actually a person who lives in the context often of a family and a social system and a social network and a community. And that integration, that property of integration, is really important for doing primary care well or not well when it's not taken into account. The 4th area is coordination, the ability to help a person navigate through the complex morass that is healthcare or through different healthcare levels over time. And the 5th is person-centeredness, the principle of being able to be known and seen as a person, to be communicated in a language that makes sense to you, to build rapport and trust with a set of providers who can then help you encourage yourself and help you attain the goals that you set for yourself as you engage in primary care. So that's the theory, but here's the reality. And the reality is we have a set of brokenness in the US, and actually it's across the world when it comes to primary care. There's a broken payment model. I would argue this is maybe the original problem or the original sin of primary care in the US, which is there was a well-meaning intention in the 70s to try to value physician services and correlate what actually makes up physician work. And this system of counting went through 3 important areas. It's first started with this committee, this relative value scale update committee we call the RUC, which what you need to know if you're a student is that it putatively represents the 33 now specialties in medicine, and of those 33, only 4 are represented of primary care disciplines. Now, that committee is important because they value services. They value the time that it takes to do a given thing, like an operation if you're a surgeon, or a visit if you're a primary care doc or a pediatrician. And the problem is the imagination and the understanding of what primary care is wasn't sufficient to understand that primary care is more than a 15-minute visit, and that surgery isn't worth 10x or 5x primary care. And so this committee would make a bunch of recommendations to CMS and to the AMA, the American Medical Association, and about 95% of these recommendations would be taken up. And what would that mean in this slightly boring part? It would mean what we face now, which is that primary care is valued financially basically with one leverage point, as a set of visits that can be coded at a certain level based on patient complexity and what you do in those visits, and yet those visits don't encapsulate those functions. They're only one small part of those functions. But if you can only imagine paying for primary care with the visit, then what happens when you need to pay for more of primary care or you need to have more of a primary care team? You ask the clinicians to do more visits. And yet what happens there when you put in overlays of now, you have this imagination that it's a simple visit and all you need to do or all you can do in primary care is more and more visits, but the reality is a complex interplay of electronic health records and patients asynchronously communicating with you after hours and important, appropriate mandates to take care of communities as opposed to just patients who walk in the door. What you get is a broken production model. The visit-based model of primary care and 15-minute aliquots cannot take care of complex populations in their social spheres, their social dynamics, their social challenges, and understanding of the now over 400 quality metrics that primary care clinicians are held accountable for. It just can't happen in a visit. There's actually a famous BU study, I believe it was done here, that said that if you just ask primary care docs to do everything that's recommended in the set of preventive services task force, that would be by itself over 19 hours a day. Every day, 365 days a year. If you just ask them to do the preventive codes. If you add the chronic codes and all the acute stuff and want to see your family once in a while, it's mathematically impossible. Okay. And it's also mathematically impossible. This is work that we've done on microsimulations. It's actually also mathematically impossible if you set up a model that looks at an average practice, 5-physician practice, in each of the 50 states, and you account for each of the idiosyncrasies of those 50 states, and you ask a very simple set of questions. Given the known disease burden and the visit types and the visit problem diagnoses, can you pay for primary care at the revenue level at a practice with existing fee-for-service codes? And the answer is no. You run it through millions of simulations. There's a 0% chance that you can pay to provide team-based primary care, minimal functions around coordination and disease registries and a couple other things that you would say these are basal expectations. There's a 0% chance that you can actually not lose money at a practice level to do this work. But it gets worse because you say, well, okay, that's okay because there are these new payment models and they have some new edges and flavors of payment. So we said, let's take the median payment. It's about $3 per person per month on top of the fee-for-service, right, the unit transactional. And let's see if you run it through the model, can you not lose money? And the answer is no. You still will lose money on almost every model. So basically what we've asked average primary care clinicians to do is take an impossible job in a broken payment model and then say, now please transform to a new delivery model with teams and taking care of communities, but take on a 99% chance of going eventually bankrupt, or you could commit fraud and abuse. But I don't suggest that as a member of Medicare because that's the one thing that Medicare does reasonably well, except maybe in South Florida, is find fraud and abuse. So this verges on slight insanity, right? Okay, the depressing part's almost over. Add on top of that very appropriate patient expectations about a 21st century care experience. I should be able to talk to my clinician, my nurse, my this. I should be able to reach you when I need something without waiting 6 days for a response. I should be able to get an appointment. Very reasonable things. And by the way, engaging with you at its high cost because I have a high deductible health plan should not put me in a financial hole and should be a somewhat delightful experience. Said very few people ever, right? Especially with this model. So we have increased expectations, we have decreased time, primary care clinicians are burning out, they're spending a lot of time on EHR documentation. They actually spend a minority of their time in front of a patient. They're spending the majority of their time, I can attest to this as a practicing primary care doctor in Jamaica Plain, the majority of their time in front of their computers or dealing with other assorted issues. So, the depressing part is over. We can take a deep breath. We have some potential ways forward. And the first potential way forward is things may be grim, but primary care has never been more important. This is a paper we did that came out earlier this year, and it asked a couple of fairly simple questions with complex methods. What is the association between primary care density measured by physicians? We would have measured nurse practitioners and PAs, but we didn't have that data. And mortality at a county level, accounting for everything under the sun. There had been state-level associations where more primary care doctors is better for state health, but states are not useful geographic entities to do these kinds of studies. We looked at county level. First point, primary care density almost across most, certainly in aggregate and across most parts of the country, is falling. That's the dark blue, is less over time. Specialists are increasing mostly, increase over time. So we have about 70% specialists, 30% primary care docs. The density of primary care docs is falling, but here's the take-home point. There is an independent, robust association between primary care physician density and mortality at a county level. And this is controlling for pretty much every variable we could get our hands on, all the usual socioeconomic status data. We controlled for particulate matter in the air pollution. We controlled for smoking rates. Anything that you can get your hands on, we tried to control in this model, and it's still a robust association. It's worth about 1 standard deviation of difference in average county smoking rates. So this is big stuff. I mean, right? Smoking is a big deal mortality-wise, as is primary care density. For specialty physicians, there was no relationship. Sorry, specialists. I'm not saying specialists aren't important. They're critically important. But I'm talking about population health, and we're in a school of public health. And so let's be really clear and real about where, if you're going to talk about the formal care system, you're going to derive some important population effects. The other interesting thing is in those counties that had either gained the most or lost the most primary care docs, we saw the largest mortality shifts and effects. So that was quite illuminating. So if we look at a macro level, here's OECD data from the Commonwealth Fund. It isn't an accident that our primary care ranking appears to be very clearly related to our overall health outcome ranking. There's clearly a relationship here that is worth thinking, and this holds true across the world. So here's where I think primary care might go, given these challenges, but these potential benefits of the functions, but the challenges that we just articulated. I think that we will go in all of these directions. And the relative power of each direction is yet to be determined, and I'd love to hear your thoughts. Now, devolution and evolution and revolution sound perhaps more dramatic than I intend them to be. What I'm going to argue to you is that they're all parts of the same coin, which is our failure to provide the core functions will lead us in these directions simultaneously. So what do I mean by that? Let's start with devolution. That sounds nasty or bad. I'm not talking about it in an evolutionary context. I'm actually talking about it in a very simple frame. That is, if you take the 5 functions and you cannot reliably meet any of those 5 functions as a healthcare consumer, what will the market do? The market will find ways of offering really valuable services to meet those functions. You may not like that, if especially my traditional academic primary care colleagues do not like retail clinics and urgent care clinics and concierge care and segmentation. I'll talk about each of these 3 things quickly. But whether you like it or not, that is what is happening in the primary care community. And it's happening for logical reasons. Let's take retail clinics. Why do they happen? because they're convenient, because you cannot get an appointment, or you cannot speak to a primary care clinician or be seen when you need to be seen. And that's an important function of any healthcare system for most of the first contact needs. And if you can't provide that, then somebody's going to provide it better than you and probably make a lot of money off of it, which is what's happening. That's the rise of retail clinics everywhere. It's the rise of urgent care centers everywhere. Now, what they're doing is they're devolving into access above all else. They cannot easily provide continuity, coordination, comprehensive care, but they do a really good job of access, a really good job, better than what my clinic, my general store can do, because they're built for access, not relationships over time. The thing about it is, though, that they're not producing what they originally also said they produce, which is reductions in ED utilization and reductions in costs. That I take them to task for, because there is scant to no evidence that they do. And these are two good studies I'd point you in the direction, which shows, number one, there's no effect on ED utilization on the left. See the curves? They're similar. P-values, not significant. The more important one's on the right, which is, it's not that people don't go to these and then substitute care. They go to them in addition. These are additive properties. You create more access, you put it at a price point people can pay, they'll use this and they'll use their other care sources. So there's a substitution and addition effect, and that's, I think, actually going to drive cost growth. So then there's concierge medicine. How do I frame this in my mind around functions? This is providing those 5 functions really well. I agree that they can provide. If I had only a tiny panel of patients, I could provide it even better, I think, but only to those who can pay, right? We'll do great primary care, and a lot of PCPs are jumping on this ship, and they're getting paid more to do less work, which, given the burnout crisis, you can't really blame them on some level. But there is there's a deep and important ethos of equity in many circles of primary care, and this does not bode well for both our workforce crisis, and it doesn't bode well for already, in my mind, inexcusable, inequitable results that we get across our healthcare system. There is a difference between direct primary care and concierge care. I'm happy to go into that in the break, but it's complex. This is about concierge care. And by the way, there's no evidence that concierge care is all that beneficial for total costs or outcomes, because it's very difficult to study and we have no national data about it. So then the third, and I think perhaps most important devolutionary trend that we see, is what I call segmentation. So these are private companies. Many of them are venture capital backed, and many do a really good job at taking care of a narrow, segmented band of often very sick Medicare Advantage patients. So Medicare Advantage is the commercial part of Medicare, where Medicare contracts with private insurers to kind of pay an overall fee, and I don't want to go too far into it, but this is an often Medicare Advantage product. And what happens here is that they select these high-cost patients really well. They wrap them around with expensive services, and the business model is making money off of the difference in expected overall spend. And they wouldn't be proliferating if they couldn't do that, right? Unless they're all fraudulent, but they're not. I know many of these folks, and they do good work. The thing about what they're doing, though, is, again, taking a band of high-cost, high-risk patients, doing really good primary care for them, but not the next band of risk patients or these non-Medicare patients, because the financial allocations, the financial risk isn't such that it's easy to make money off of a commercially insured population. So this will continue to grow as a trend. Again, all the 5 functions for a small band of patients, but it's not going to solve our general problem. So then what is? Well, a lot of people, and I've been part of this movement, say that it's been going to be evolution through the medical home movement and incremental payment reform. I hope I've at least argued somewhat well that you can't really pay for the primary care you wish to see with the current payment models. Happy to take that side of the debate later on, but I think that that's a fairly proven point. So what do you do? So then there's this pretty poorly named thing called the patient-centered medical home. What does that even mean? Like, my mom said, I didn't realize you work in a nursing home. And I was like, I don't work in a nursing home. She's like, well, you said you work in a medical home. I was like, oh, yeah, it's it. So it comes from pediatrics in the late 60s, caring for kids with multi-system conditions like cystic fibrosis, co-locate specialists and social workers and primary care docs around their care, and good things happen. Went to the family medicine world in the early 2000s, and then finally the adult internists figured it out about 10 years ago. And so what is it? It's the 5 functions, great primary care. Through the 5 functions we can measure, we know what they are. Delivered by a team, that's a big difference, not just by a hopelessly, running hamster wheel physician, and it's connected through health IT. That's what patient-centered medical home. And when it works, it's the center of locus of accountability, of production of a new type of healthcare model, producing those 5 functions. And it can work, but I always get this. I've done a lot of work with many others. Some of you in the room have also done work. So we get this question, does the medical home model work? And I always take like a big sigh, because it's complicated. And I know people don't like the word complicated, but it really is. So before you look at the evidence, I would say here's the sociology of the medical home movement. I put akin to the Gardner hype cycle, which is about tech innovations. Gardner hype cycle says there's this trigger, iPhones, something else, social media. Then there's this peak of inflated expectations. It's going to solve the world and bring people closer together. And then it may also undermine democracy. And then we hate social media. We hate now you kind of understand in your trough of disillusionment. Maybe there are more productive ways to slowly increase that slope of enlightenment and get to a plateau of productivity. And I would argue we in the medical home movement are about early parts of the slope here. So we have positive evidence that it almost certainly improves many processes of care, especially for chronic diseases. It appears to improve teamwork and trainee experience, some chronic disease outcomes, some ED utilization in multimorbid, chronically ill patients, and probably improves patient experience after an initial nadir. What it doesn't appear to reliably do is reduce inpatient utilization, and certainly net of the costs it takes to build these medical homes and to transform teams and to pay for new team members, it doesn't appear to reliably reduce total cost of care. And here I don't know what it does about burnout yet, because it's really hard to do, but it's probably the long-term answer, so we're in betwixt and between. What I can tell you is, and this is like my guilt admission part of the speech, is that I was part at the early phases of, I think, overselling. And this isn't like just what I did, but many of us as primary care advocates and researchers and practitioners probably oversold the model. We thought that in order to get traction for an often ignored part of the healthcare system, we had to promise the triple aim. Berwick's, increase outcomes, improve experience, reduce costs. Like, that's so easy to even do one of those things reliably. We promised them all. And we promised them all in order to get funding and attention. And I think that promising a reduction in costs, certainly the empirical evidence would suggest it's not there. And probably care coordination, because that was the putative mechanism. We're going to coordinate all these sick patients, and then they're not going to end up in the hospital. But you've seen if you work on readmissions, if you do enough studies, it's really hard to keep people out of hospitals. It's hard to know when you can you can keep people out of hospitals doing inappropriate things. It's hard to know when you can appropriately keep people out of hospitals, and hospitals are built to drive their own demand. And that's a kind of health policy truism. And so I'm not sure at this point, actually, I'm pretty sure that we can't really inflect the total cost curve, but I actually think that's the wrong argument for incrementalism and for medical homes. I think that they exist, like primary care exists, to improve care, to improve people's experience of care, to engage communities in producing health, and that can be reliably done in a cost-neutral format. That I'm willing to take to the bank as an argument and informs a lot of our work. Now, there are lots of different ways to pay for primary care and actually healthcare. I put them in all this acronym soup on a simple little linear line. So on the left, providers take more risk, right? Providers take less risk and insurers take risk in terms of fee-for-service, right? Because the provider can just keep churning through more visits, more, and the person left holding the bag is the payer or the purchaser. On the right is global budgets or capitation. The providers take more risk because they're held to a budget. Payers have less risk, but providers hate it. And in the middle, you can do all sorts of fancy or not so fancy things. You can bundle, you can make episodes, you can add layers of predicted annual expenses to the fee-for-service chassis. And that's what we've been doing at Medicare. We've been using a lot of these different payment models to build, as Michael talked about, one of the largest primary care tests of matching a new set of parsimonious pathways for delivering primary care through teams and IT, and then ratcheting up different payment mechanisms and risk models. So we have these 2 tracks, each about 1,500 practices. They didn't fill up the models as we thought they would, but we have, as we said, a lot of people, and we have a lot of payers. We have not just Medicare, but almost 80 payers. And it was really important to build this model across these states here with MultiPayer involvement. Because as you can see, one of the things that makes all of this stuff collapse is if a payer takes on providing extra capital or providing extra money for primary care, and nobody else does. First of all, it's really hard as a primary care team to be like, okay, is that a Medicare patient? Is that a Blue Cross patient? Okay, I'm going to give them extra services, but not you. That's unethical, and almost no primary care clinic will sign up for it. So what happens is that there's all this cost sharing, but then the payers get mad because of the free rider problem. And so having a multi-payer model in which at least 60% of a region's revenue, or for that given practice, is coming through a new payment. Remember, in the US, we can't show each other our payments. That would be forms of collusion that would violate antitrust provisions. But we can all come around a table in a kosher way and say, are you agreeing to pay differently? Yes, we in Medicare are. Here's our model. Are you agreeing, Blue Cross? Yes. We're not going to show you the amounts, but we agree. And so all of a sudden, for these practices, you have a new stable, at least for the life of a test, model. And this can add up to real money. I mean, many of these practices, they got $200,000 to $300,000 of extra predictable revenue. And some of them were getting it through new prospective payments where you capitate the payment. So it's not just on the visits that you churn, but also you have a predictable prospective payment. Half the practices are in each of the tracks. Half of them also participate in ACO models, the SSP models. Lots of vendors are participating and lots of patients are participating. And what we stumbled upon, especially in track 2, which has this capitated model, is that it actually appears that its predictability and this increase in funds that comes on a monthly basis outside of visits seems to line up with some of the simulation and theoretical evidence. So here's a paper that our group did independent of CPC+, but we basically found that, remember those practices that could be basically guaranteed to lose money on average fee-for-service, or even a little smattering of the new payments? What could happen once you capitate them at a sufficient amount is that at about 63% or so capitation, they have a less than 5% chance of losing money. Now, it assumes a high enough level of capitation, but it's all about these complex fund flows and having a different predictable source of revenue. And that's really important, because what we're doing at CMMI is moving the gradient above, up and up. If we started in track 1, with no capitation, now we have partial capitation in track 2. This next model that's coming out probably in 2021, called Primary Care First, offers practices the option of fully capitating all of their Medicare payment. That may sound like the most boring thing you've ever heard, but it's kind of a big deal health policy-wise, because before we were having discussions about, well, Medicare shall not capitate, it's just not possible. And now we're having discussions about, well, what happens if we fully capitate practices for the 20% of patients that are on Medicare, but then their 80% of patients are still on this kind of funky fee-for-service? That's a big question, but we'll try to answer that. And then even if you build these new payment models, you have to figure out ways of transforming. And if you want to read articles on sort of what we're learning after 10 years of transforming the day-to-day grind, many argue that they're system-level enablers like payment and facilitating practice transformation with coaches and data and better EHRs, and then they're practice-level tenets of focusing on whole practice change, not just like for diabetes or behavioral health. pacing yourself, so not doing everything all at once, focusing on what matters most to the communities that you serve and involving them in the practice transformation from the get-go, and then practicing regular QI hygiene, which I know sounds funky, but that just means having a method to transform, using data, meeting regularly, breaking down hierarchies in your practice, and knowing that you're going to fail a lot before you actually get to any stable level of success. So that gets us in the last couple minutes to this revolutionary part of the talk, which is what would happen or what's going on in terms of thinking even more broadly. And here, this involves really rethinking payment at an even more broad level, but also reimagining primary care, and I'll give you a couple examples. Now, this is by no means likely to happen, and there are only a few little points that I can point to this stuff happening, but it is interesting that it is, and there's nothing to say that it couldn't catch fire a little bit. So first, we start with the spending graphs. Here's the US over time. I call this the Wayward Worm. We just kind of inexorably increase in costs with not much value to our population or our healthcare system. Now, this is for especially students in the room. It's not really what you think in terms of increasing costs when compared to a bunch of other OECD countries. So it's not that we have more physicians, really, or really use or have more hospitals per population than most of these countries. It is, as your professors will likely tell you, I hope, or maybe they'll argue and tell me I'm wrong, but it is likely about the prices and about technology, our inexorable march to do and be able to do more and more and more. I mean, in the 1960s when Medicare was created and it had usual and customary fees, basically doctors could ask for whatever they wanted because they couldn't do all that much, to be honest with you. Now, when you have 400 quality measures just for primary care, and you have CAR T cells, and you have all sorts of just wildly expensive innovations, you can do so much more, and you can charge so much more doing it. Look at what you can charge in the US for things like bypass, and this is old data, bypass surgery, 2x, 3x variation, 4x variation for simple things, right? Another really annoying fact for the students, ask your professors about this. We often interchangeably use things that shouldn't be interchanged. So prices are not the same as charges, which are not the same as costs. Discuss. I'm not going to get into that. But that's part of this problem is when prices don't equal costs, don't equal charges, we get into some of the morass that you have some of the most august people in the rooms who can tell you all the fun and depressing facts about that. But it's not just the prices, it's the distribution of spending. So here's new data from a couple months ago for those states that we have on proportion of total spend of the healthcare dollar on primary care. Green, which is putatively good, darker, is still not very high. It's like 12 to 14%. And these are like very wide, like primary care is inclusive of home care and rehab, which it really isn't. So these are almost certainly overestimates, and lighter colors are lower amounts of spend. But look at this, just correlation, I grant. I'm in a school of public health. Correlation is not causation. But just look at the relationship between primary care spend and ED visits. There's something there that's worth mining. But there's something much stronger that's worth mining. So here's a study that we did about Rhode Island. So 10 years ago, my friend Chris Kohler, who was at the Office of the Health Insurance Commissioner in Rhode Island, said, you know what, I'm sick of this. It's not right that primary care basically gets 5% of total spend and yet has all this value and all this importance. And he looked in the Rhode Island state manual and code books and regulatory apparatus and said, you know what, I can actually mandate that the commercial payers in my state will have to double their spending on primary care over the next 5 years and in cost-neutral basis, meaning they can't just double it by charging the purchasers or the patients more. They have to double it at a neutral basis, and the only way to do that is, of course, to cap hospital price growth. Ooh, now this is kind of revolutionary. You can imagine what my alma mater's institutions at Brown and other provider groups thought about this, but they had to do it because they could not reject or deflect this. And what happened? So we followed a cohort of patients who were commercially insured, that's the blue line, and compared them to a control group in the 49 other states and tried to control for everything under the sun. And this is a really nerdy point, but this is a very rare thing to see. This is a bent cost curve in the wild. I know, we often talk about bend the cost curve, but you can't bend the cost curve in commercially insured patients very easily. But it appears, and I grant you this wasn't a randomized setting, but it appears that Rhode Island did something. Now let me bring back uncomfortable truths. As much as I would like to tell you, because I love primary care, that it was because of primary care's impact on ED utilization and hospital admissions, I can't tell you that because there was actually no change. What I can tell you is that capping hospital price growth helps you to reduce overall costs because hospitals are the source of cost growth. And the good thing, as you start to look at this, is it's not that basic because the money that went into primary care went in to build one of the best infrastructures and one of the best medical home rollouts statewide that we've seen with real quality and patient experience benefits. So what the Rhode Island experience argues to me is that at a cost-neutral basis for the state and cost savings for some commercial insurance, you can actually get better primary care outcomes, but not through the usual mechanisms, by starting to rebalance that spending. And lo and behold, last week, our governor and his legislative aides announced in their new bill, not because of this paper, let's be clear, but because actually this is catching fire in Oregon and Colorado and other parts of the country, that part of this new bill that they're sending to the legislature is to say that they're going to ask for a 30% increase in primary care spend at the payer level over 3 years. And this is really radical. This is like, whoa, health nerd foundation shaking right now. They will actually ask it at the provider level. That means Massachusetts ACOs, of which I may be a part of one. That's really expensive, and which pays its primary care doctors in a modified fee-for-service way, even though it's on global budgets from the commercial insurers and from Medicare and now Medicaid, but the internal accounting is still fee-for-service. And they say, hey, Asaf, we're not seeing the visits that we need to see. Maybe we need to ratchet up those visits. And you say, hey, I'm trying to take care of a population of patients. That's what we signed these contracts that you've talked about all over the country. And you're telling ratchet up the visits? What about all the other things that we want to do? So not much has worked to kind of tackle this incongruity for the last few years, so maybe this will. We shall see. So back to the Wayward Worm. The Wayward Worm is really interesting because our costs are not so much that when we combine health and social spending, we spend more than any of our European and Asia Pacific friends. It's that our distribution between costs is so wacky. Most countries spend 2/3 of their dollar on health-related spending on the social side of health-related spending, and we spend 2/3 of the dollar on the formal care system and less on social care spending. There lies some potential. For those of you public health students, you probably recognize this most famous map in all of public health, and I was there this summer. There's the famous pump. It's not actually the pump, but it's a pump where John Snow did the cholera work, and everyone knows this map. I think actually this map is way cooler. This is Chadwicks Map of Leeds from 1842, and I have a copy of this, so I took a picture of it for you guys, because I just think this is so awesome. Now, Chadwick was crazy, and he actually, in many ways, influenced this. But one thing that he did that we owe him credit for is he's probably the first to map the overlay of the blue dots, tuberculosis deaths, and red dots, diarrheal deaths, with this shading system. You see this yellow? That's not like mold. That's actually his shading system for social deprivation. So he combined mortality data with income data, which is wacky. And he was like, how about the fact, I'm not going to do my bad British accent, how about the fact that mortality seems to cluster in the poorest areas? Isn't that interesting? And he became a social crusader. Unfortunately for us, and this is our public health historical allude, the reason he's related to this is it was Chadwick's miasmic theories of disease caused by smell that actually led to the initial sewage system of London being poured into the Thames River, because it couldn't be that the water was the problem. It had to be the smell. And if you push the smell into the sewage and just put the sewage somewhere upstream as it flows downstream, it would be fine. And no one was willing to think of the waterborne theory until it was too late. But we digress. These maps are really important. And they lead us, there is a connection, I promise, to a way of thinking about perhaps if we really want to do something revolutionary, we think about primary care outwardly as a part of a social care system. And we have models for this. This is South Central Foundation in Alaska, the Nuka care system. Probably the best primary care system, certainly in the US, maybe, I don't want to say in the world, but this is a really good primary care system. It's an Indian Health Service run area. It treats some of the most poor and sick and disadvantaged Alaska Native communities in all of Alaska. High burden of disease. And what they've done by reimagining the model of care is amazing. So they built teams first, and the teams take care of the populations, and the teams have integrated behavioral health. And they go out and do a lot of outreach in the community, and that's great. And then they started to reimagine the job of primary care physicians as seeing the sickest patients, and community health workers and nurses as seeing the less sick. They built protocols, they built it with community members, and they did something amazing. And they did this by taking Medicaid block grant waivers and investing in things that usually health systems don't invest in, like not hospitals, but more community-based programs. They did, because I know that maybe you missed last month's copy of the International Journal of Circumpolar Health, so I'm just sharing it with you. It's a real journal. And in that journal, there's, not last month, a couple years ago, there's the usual, these are emergency room visits and their decline over the last 15 years since the introduction of the program. Awesome. So they can reduce utilization. That's great. But that's not the curve that I'm interested in. I'm interested in this curve. This is a wild curve, if you ask me. This is rates of emergency care use for unintentional injuries in this area. The principal driver of which is accidents, the principal cause of which is, besides snow, drunk driving. Epidemic levels of drunk driving. So this primary care system reimagined its social compact with this community, which is not small and not over a small area, and has actually deflected population-level outcomes. Drunk driving accidents. There's no other alternative explanation for this either. So that we think this is real. And I've spent a lot of time with them. They do amazing work. They have a totally reimagined system. You see a few patients in the morning, and then you work with your teams on community health and public health in the afternoon. I've seen this and studied this in Costa Rica as well. Very similar system, empaneled group of teams, mainly in the community. They go to every house once a year. 5,000 people for every team. They have better outcomes than the US at a tenth of the cost. And it's not because Costa Rica doesn't have an army or has high rates of equality. It's actually because the primary care system is that good and that integrated with the social care system. And finally, I would end by saying there might be new paradigms for measurement if we think in this revolutionary way. Instead of thinking of the usual technical process measures of care, did you get your lipids checked and your A1C checked for diabetes? Those are important. What if, and those of us at the named Starfield Summit are thinking about, what if we actually measured the things that matter most to patients by asking them what matters most? And it turns out what matters most to patients are things like, my doctor and I have been through a lot together. This doctor of practice knows me as a person. This care I get is informed by knowledge of my community. This helps me meet my goal. Now, I hope some of you are working on measures like this. I think this is potentially a real paradigm shift in terms of the future of measures that actually matter to people. You can say it's satisfaction, but this isn't satisfaction. These are deeper properties and principles of being known, seen, respected as a person in a community. And finally, on measurement, and this just gets into our global work, we've been doing a lot of measurement with countries across the world on measuring these kinds of things, including finances, their capacities, their performance, and their equity. And so we're doing this at a country level, initially with these countries, now with 15 countries and moving to 60 countries. So if we can do it at a level with countries that have a lot more challenge in terms of other parts of the health and social care system, I think that we can do that in the US. So I'm going to end with 6 predictions. Primary care is going to survive. It's going to be more important than ever, and the values and the functions. We'll provide primary care differently through teams, and patients have to be part of that transformation. We'll measure it differently, centered around patients' functions, needs, and what's most important to them. We'll pay for it differently, around bundles and episodes and prospective payments, and the visit will stop being the unit of production and will increase the proportion spent on primary care. Care will be oriented toward building healthy communities and addressing social needs and behavioral health, and this will enable a massive need for innovation. So join the fun. Thank you.
Questions galore.
Thank you very much. This was great. We were chatting earlier. We had a few minutes before the session started, and there was pretty broad agreement that we're running out of primary care docs. We're not going to train enough of them. So you're talking about primary care, but you're not necessarily talking about primary care docs.
Correct. Yeah, I'm a doctor that's not stuck on my own guild or tribe. I actually don't see an easy way to train and retain the number of primary care physicians that we need to do this work. And if you look at the comparative health systems across the world, that may not be the worst thing. I think they have a different conception of what primary care physicians do. They tend to stratify them and have them see more complex patients, manage teams, do a lot of different tasks that right now we have kind of a Marcus Welby or Marcusette Welby. I'm trying to think of like the male and female version. So we have primary care docs that are doing general store, general practitioner stuff, me included. And I'm not sure that that's a sustainable model when we have such a sort of crisis of access. And it may be that we need to expand our PA and NP and team-based care models to sort of make up the difference, I think for now or for a long time. Or we could, as Alan said, we could just pay primary care docs a lot more, and that might change that. Now, the UK did that and through pay-for-performance schemes, and that only had a not quite lasting effect. So we can talk about that. Please. And if you could introduce yourself or say.
Hi, thank you so much for your talk. It was wonderful. My name is Madeline. I had a question related to the kind of the devolution versus the revolution. Especially with the kind of proliferation of urgent care clinics, especially urgent care clinics that purport to offer primary care as a primary service. Do you think that with these forward-thinking models and what we're seeing coming out of CMMI, there will be kind of a die-off of those services, or do you think that instead the pressure will be to have those urgent care clinics that are trying to fill the primary care space, try to meet those goals as well and revolutionize the way that they're giving primary care?
That's a great question. I think the issue with those clinics and the business models behind them, and by the way, Walmart and CVS have been trying to do this. CVS, for the last 3 years, they've been trying to expand their idea of an urgent care center or retail clinic to even include these 5 pillars of chronic disease and do some continuity-based care, and they can't do it very well. Walmart tried too, they can't do it very well. So they may try, they may, see the market opportunity, there's $60 billion here, but it's really hard because it kind of reminds me like 10 years ago, I remember talking about the medical home and to non-primary care specialists, and many would say, I remember I was talking to urologists, and they were like, we're a medical home too. Hey, we're a medical home. We want that extra payment. And I would say, if you want to be a medical home, amen. I have no priors on who can do this work, but let me tell you one inconvenient fact. Or others would be like, I'm a pulmonologist, I do those things. And I'd say, I know you build relationships, and you're great doctors. But if you want to do this, you have to do all of it, or you're not doing primary care. And that's the problem with these retail clinics. They say they want to do more than access, but then when they get into the contingencies, the complexity of doing coordination and continuity, they're like, well, I'm not sure, we didn't really mean that. Can we just bite off these little segments and make some money off them, which is fine, that's cool, but that's not doing the functions. And what I would argue is that eventually that will catch up to patients. Patients will vote with their feet. They'll still use the access when they need it, but people still want long-term healing relationships over time.
Thank you for your lecture. My name is Isha.
Isha works with us at Area.
Going to your example about the Indian Health Service, do you think that system of empanelment can be applied to the larger U.S. healthcare system and primary care system? Or is that, because it requires so much diligence and a lot of time and thought to be put into that, can that be applied to a larger population level?
Yeah. So would Isha, who's also a student here too, so both. Empanelment refers to the property or the principle of a health system knowing who it serves and making sure that they agree to be taken care of. You can also not have them agree to be taken care of, but it's that you don't just serve the people who walk in your door on any given day. Empanelment is a hallmark of effective primary care systems. It's easier to do in rural settings like South Central, much harder to do in urban settings that are mobile, in which people have insurance coverage that shifts year over year and provider networks that move. So it becomes much trickier. Now, I wouldn't give up on empanelment too soon, though, because just because you may have voluntary empanelment or insurance-mediated empanelment, you only can go to this set of clinics, doesn't mean that those clinics year over year shouldn't aim to know who 90 or 95% of their patients are. So, because otherwise, the ability to proactively reach out and push some of the population benefits of primary care are lost without that ability to know who is in your denominator. It's just harder in urban environments with high population densities and mobility, insurance or otherwise. Someone has to disagree or something.
Thank you so much, Franz Berthold. In your kind of forward thinking in the evolution of primary care, how do you see that reconciling with kind of the constant consolidation of healthcare and the healthcare landscape, large systems buying small, networks of physician practices? Kind of how will your model be sustainable in that kind of arena?
That is one of the central challenges in evolution, because you have market consolidation. Most of that consolidation is happening centralized or around hospital-centric health systems that are oriented to do what hospitals do. And they do a good job of that. And then they buy these practices. Maybe they bought them 10 years ago so that they could feed referral volumes. And now maybe 5 years ago, they bought them on the notion that ACOs, accountable care organizations, would need a base of patients to build a global budget around. And that may or may not be true, but the consolidated hospital-centric system and its, I would call, fake accounting mechanisms for primary care, where a hospital in fee-for-service sees the hospital as the center of revenue and primary care as a loss leader, when actually that's not even true, because how do you think radiology and specialists get their revenue? They get it through primary care-based orders and volume. But even if we'll grant them that absurdity, in an ACO, theoretically, primary care becomes your revenue center, your base of patients you're accountable for, and hospitals and specialists are your cost center. For some set of complex reasons we should discuss, that thinking is not ever really bled into. And so the challenge is to get people to do the accounting right, or to get out of that business and have more of the effective ACOs be primary care led. But that's a really market by market level fight that I'm not sure we're getting a lot of traction around. So I have no good answer for that except to say you're 100% correct. But I do believe in truth in accounting, and there's a lot of untruth in accounting within healthcare systems right now.
Can you hear me? So in the Alaska example,
Yeah.
primary care providers think of their, let's call it a population, as
Yeah.
we call it in this school, a population, as the same or contiguous as their community?
Yeah,
But that's not necessarily the same in Boston.
correct.
So how do you differentiate community versus the population, and how should primary care providers think of those two concepts?
Well, it's certainly, as we said earlier, easier in geographically bound, single town, tribally run communities in rural areas. There are a multiplicity of overlapping, mobile, moving communities, and that complexity doesn't absolve primary care of its core responsibility to do its best to know who is in its population, who is in the denominator of the impaneled group for which you care. And though that is hard, and though you'll never reach 100% perfection, there are a set of better techniques, tools, protocols that allow you to know, with a combination of insurance data, clinical, electronic health record data, voluntary assignment and alignment data, who the majority or the vast majority of your patients are in a given time period, who runs in and out of your system, and who you should reach out to, most importantly, because this isn't a theoretical exercise, who you should reach out to that might benefit from the functions that you can offer. So it's just harder. It's not that it can't be done. Last question.
Hi, so my name's George. My question is, how do we really sell care coordination, not just to primary care docs, because I think they're already pretty much convinced, but to specialists and other points of contact in the delivery system? Because when I worked at a patient-centered medical home, I would spend hours in my day reading notes to then summarize and forward to our docs, putting together packages to be sent off to specialists, so they would be prepared to see our patient. And more often than not, when we'd get the note back from the specialist, they would have totally disregarded anything that we had sent them.
Yeah. If you got the note back.
Exactly.
Which is only 38% of the time.
I was 100% of the time.
Hey, Air 5 right there. Nice work.
That was the rest of my
I was
day.
just giving you national averages. Well, look, I mean, first of all, for care coordination to have any benefit, it has to be recognized as a core function. And I think we under-recognize it at our peril, right? So the fact that we've rediscovered or discovered care coordination in the last 10 years in adult medicine is kind of nutty, because it never went away. Our systems got more complex and fragmented, and we worried and wondered about why they were so fragmented. And it's in large part because the connective tissue of the organization that knit the health journey of a patient together. First, primary care docs left the hospital because it was too complex to both care for your patients inside the hospital and in clinic. And then once they left the hospital, then the connections with what were smaller groups of specialists, and now it got more frayed because people went to larger group of specialists, and EHRs were way behind if they were even there, and so there were information feeds. So now we put in, like your job that you're describing, care coordinators, and it's a Band-Aid over a still open wound, because when you're running around both as a primary care doc or as a specialist, mostly seeing patients in visits, because that's your unit production model, you're neither paid nor expected nor assumed to read your fantastically crafted notes. But if you change the expectations, the measure sets, the compensation, and the whole rules of the game to say, how could you not do that if you're actually going to care for this population of patients? That's the theory that would say, not just a set of incentives, but new professional norms that you can't live without this. The problem is, it's not 100% clear that all that work facing a torrent of fragmentation can immediately or in 5 years reduce ED utilization. But it's still valuable work because it's what people want and it's the right thing to do, and it's what leads to improved care outcomes, if not utilization. And so we have to just get the language a bit right on what we are and are not doing, what we should and should not be doing, and what the whole point of the primary care edifice is.
Thank you for a fabulous talk. Thanks for attending.